Hey everyone, so in today's video we're going to discuss some key features surrounding foot and ankle behaviour, specifically talking about ankle dorsiflexion and foot pronation coupling behaviour, or this intersegmental coupling behaviour, and why we need to be more, or why we feel that we need to be more mindful and thoughtful when we're using these coupling behaviours to guide our thought process during assessment and rehabilitation. Okay. And I'll discuss briefly where I think some of the issues have emerged from, and really they've emerged from the use of different mental models to guide our thought process. And remember, a model or a mental model is a collection of beliefs, of concepts and ideas that you use to make sense of incoming information. The model acts as a filter, and then everyone takes in the same information, but based on the model that we're using, we'll interpret that information differently. And one of the models that you'll see floating around in the rehab space now is using gait as a model to guide our thought process during assessment and rehab. Now, what we need to do there is we need to understand that gait is just one task. It is an important task. We'd be in trouble if we couldn't walk and run, but it's not the only task that humans will express, or that individuals coming to see you with movement limitation will demonstrate difficulty with. Okay, so characterizing what gait is a movement task that is characterized by a sharing of range of motion across multiple joints, a sharing of muscular load across multiple muscular tissues. So it doesn't really involve a concentration of motion at a single joint. So for example, if we're looking at ankle dorsiflexion and foot pronation coupling, during the stance phase of gait, when we have that tibia and the rest of the body transiting over that foot segment, we're not only concentrating motion at the talar crural joint, the interaction between the tibia and the fibula and the talus, where the tibia is moving over top the talus without any motion at the foot. There is motion that is expressed within the foot as well. So we couple ankle dorsiflexion with foot pronation, but it doesn't mean we're taking that ankle dorsiflexion to the extreme end range. That would be very difficult to do, especially if you look at things from a muscular force generation standpoint. We don't only concentrate muscular force generation via ankle plantarflexion. We couple that muscular force generation, or we share that muscular force generation with knee extension, hip extension. Okay, so it's not a concentration of load via one isolated muscle group. It's also not a concentration of range of motion at a single articulation between two interacting segments. Okay, that's important because what you'll oftentimes see now across Instagram, across the rehab space, where if someone has limitations with ankle dorsiflexion, people will say, oh, ankle dorsiflexion couples with foot pronation, so you need to improve foot pronation to improve your ankle dorsiflexion. Well, that's not true, because foot pronation is a different expression of segmental behaviors. Foot pronation is a subtalar joint range of motion demonstration. So foot pronation is characterized by calcaneal eversion and a adduction and plantar flexion of the talus. So if you watch the talus there, I'll try and do a kind of a close-up as well. I'll position it somewhere on the screen here. But as that talus drops, which is a plantar flexion of the talus, and it deviates medially, which is an adduction and a deduction of the talus, that will couple with calcaneal eversion, and that will allow for an unlocking of the tarsal bones and a depression of the medial arch, creating foot pronation. What happens when ankle dorsiflexion and foot pronation coupled with each other? I want you to watch really closely the tibia and the talus here, is that if we're trying to bring that tibia over top the talus, and with that tibial motion, this is a forward rotation of the tibia, we've discussed this in previous videos. If that tibia moves forward or rotates forward and the talus drops, you see how the tibia is moving further forward, but there's actually no relative movement occurring between the tibia and the talus in that situation, because the tibia, or the talus, the dropping of the talus is just dragging the tibia forward in space. Okay, so hopefully you can see the difference between that and then this. Okay, one is allowing for a range of motion to be concentrated at the talar crural joint. One is just two segments moving in similar directions, and that will typically couple with an internal rotation of the talus, of the tibia as well, with the dropping and medial deviation of the talus and the eversion of the calcaneus. Okay, so that's important to consider there, because now the tibia is moving forward in space, but it's not moving relative to the talus. Okay, and that can certainly help the tibia move further forward in space. So we're not saying that coupling foot pronation with ankle dorsiflexion doesn't allow you to get the tibia further forward in space. It absolutely does, but we have to consider that it requires a sharing of motion between multiple articulations, multiple interacting segments. Okay, really important to consider that there, and we'll talk about the different foot behaviors where it's important to consider this towards the end of the video as well. And this is something that was brought up very recently in an Instagram post of ours, where we spoke about the importance of being more mindful about foot behavior when the intention is to concentrate motion at the talocrural joint, the interaction between the tibia, the fibula and the talus, but mainly the tibia moving over top the talus. So we spoke about that in a previous video as well, so check that out. But briefly, we spoke about how we want to get toe extension, metatarsal plantarflexion to enable a lifting of the medial arch, and if we take that further back into the rear foot, which we didn't discuss in previous videos because it just is a bit more complex, that lifting of the medial arch is going to create a dorsiflexion of the talus and the rest of the foot segment, but it will also create an abduction of the talus. That's why the foot will narrow when it supinates. And during pronation, the talus will drop or plantarflex and deviate medially, which is an adduction or a movement towards the midline of the body. And that's why the foot will often widen during pronation. But that will also couple with calcaneal eversion and tibial internal rotation as well. So we want to try and reduce that tendency to drop or plantarflex and medially deviate the talus, because when that happens, this typically happens. So we're not getting any dorsiflexion at all. And I see this clinically an awful lot in clients where, and I'm sure you see it too, where clients will have a lot of pronation behavior. They'll have a lot of calcaneal eversion, a lot of tibial internal rotation, a lot of dropping in the medial arch. But when you check ankle dorsiflexion, particularly when you try to position their foot in more supination, they have a lot of limitation in ankle dorsiflexion. And oftentimes when you watch the clients demonstrate the things they have done in the past to try and improve that ankle dorsiflexion, you'll see, different dorsiflexion, plantar flexor stretching tasks up against the wall. But if you're looking from the rear view here now, when they try to bring the tibia forward over the foot segment, you typically just see them drop in like this. And so again, there's very little relative movement occurring between the tibia and the talus in that situation there. So that's why we need to be more mindful of foot behavior relative to the behavior of the tibia and the fibula over top the talus. Okay, and again, I'm not saying that using gait as a model to guide your thought process is wrong or useless. It absolutely has utility, but we also need to understand that if individuals demonstrate limitations in local range of motion between two articulating segments, then using these coupling behaviors to guide your thought process are no good. We don't want segments to move in the same direction like we would in gait. That's like saying that in order to improve humeral internal rotation, I want the scapula to also move in the same direction. I have a lot more motion at the humerus when I do this, but if I pin my scapula back into external rotation and try to concentrate that rotation at the humerus, I have much less range of motion. I have much more when I let the scapula dump forward with that motion. So they're moving in the same direction. One segment is dragging the other segment in the same direction. But it does not mean that I'm getting that range of motion between that articulation that I want to get range of motion between the humeral head and the glenoid, the scapula. Okay, so really important to consider that. So let's think about this clinically. And let's discuss this within the context of two clients, both that have a limitation in ankle dorsiflexion. So you can have a client that has a limitation in ankle dorsiflexion that has a lot of foot pronation. They have a lot of calcaneal eversion, a lot of dropping medially of the talus, a lot of depression of the medial arch, a lot of tibial internal rotation, but they still struggle to dorsiflex the talocrural joint. You may also have a client that has a limitation in ankle dorsiflexion, and they lack the ability to pronate the subtalar joint, okay, to evert the calcaneus, drop the talus down and medially to create that depression of the medial arch. You may, and from an ICAM perspective, we approach these in different ways. If, for example, you have the client that has limitation in ankle dorsiflexion, but also a lot of foot pronation, you have to position the foot in more supination and organize those segments in a certain way to concentrate that motion at the talocrural joint. Now, what you'll often find in these situations is that when you do that, you may have to tweak things slightly, because oftentimes these clients will feel some limitation, maybe a slight pinching sensation or just some sensitivity through the anterior ankle as they bring that tibia over top the talus. That doesn't mean you need to get that talus out of the way. That just means that they're sensitive, because you are going to get some contact between those joint surfaces, which is going to create some load between those joint surfaces or on those joint surfaces. That can be sensitive if you have not experienced that before. It doesn't mean you just dump the talus down immediately to get it out of the way and think you're bringing the talus further forward, because you're not getting ankle dorsiflexion in that situation, okay? So that's fine to do if, for example, in the early phases, if you have a client that has limitations in ankle dorsiflexion and also has a very supinated foot, because they may not have that opportunity or that ability to drop that talus down and in, okay? So sometimes we find getting motion into the foot between the rear foot, midfoot and forefoot can be helpful to influence the tolerance to that range of motion between the tibia and the talus. Because if everything's been lifted medially for so long, that talus has been dorsiflexed and abducted for a long period of time, then we are experiencing potentially some sensitivity through those two interacting segments, because there's a lack of variability within the foot. So early on, and you'll see this in a client's during the foot within the foot and ankle section, where we coupled foot pronation and ankle dorsiflexion to get some load into the plantar flexors while the foot was more pronated. But we're doing that to share some workload and some range of motion into the foot early on. But we do ultimately want to come back to continue to try and concentrate that motion between the tibia and the talus at the talocrural joints. But it's just about trying to influence the tolerance between those two interacting segments in the early phases. And that's why it can be helpful to couple dorsiflexion and pronation in the early phases in that specific foot and ankle behavior, limitation in ankle dorsiflexion and a lack of pronation or a lot of supination. Whereas in the client that has a lot of foot pronation, a lot of calcaneal eversion, we want to try and limit that. We still may experience some sensitivity, but we also want to ensure that we're just gradually exposing the individual to that. So it's not necessarily always a qualitative issue in how we're organizing muscle and joint behavior, but it's how we're dosing that muscle and joint behavior. So you don't just get someone into supination and then drive the tibia over the top of the foot segments with a lot of load and a lot of duration, a lot of volume, a lot of frequency early on. You gradually promote that forward rotation of the tibia and get load into the plantar flexors, get load into the toe flexors as you promote that range of motion, okay? And work with the client's feedback. Do they experience too much sensitivity through the talus? Maybe you can drop them into a little bit of talus, plantar flexion and medial deviation early on, not through a lot of calcaneal eversion, but just gradually expose them to that supination and that talus dorsiflexion and abduction gradually throughout the process of promoting the ankle dorsiflexion, okay? So it's a matter of having a clear intention. If your intention is to promote ankle dorsiflexion, then you need to promote relative movement between the tibia and the talus. If the talus and the tibia are moving in the same direction, the tibia is going further forward, but it's not going further forward relative to the talus. Both of them are moving in the same direction, okay? But when we're working with real clients that have sensitivity, pain experiences, injury histories, we do have to use their feedback to guide how we dose the application of load, whether we're trying to create range of motion or improve muscular force generation capacity. So I do think that a lot of therapists, coaches, trainers will have a client feel that little bit of a pinching sensation through the front of the ankle and say, oh, we need to avoid that. It must be that talus is too far up, and then they'll just drive it inwards. But what if this is already a client that has good calcaneal eversion and a lot of foot pronation? Then that's not really offering us a valuable solution. Okay. Now, what you'll also see on Instagram is people talking about true pronation behavior and how pronation needs to occur with ankle dorsiflexion. Okay. Now, what those therapists often mean is that they want to try to create a pronation at the foot via the mass or the weight of the body coming over top the midfoot to drop that down. So they're not getting that through calcaneal eversion. Okay, so they're all ultimately saying that they want to get pronation, but they don't want to use a very calcaneal dominant strategy in order to achieve that. That can be helpful, again, in clients that have a lot of calcaneal eversion. Maybe that's creating a little bit more sensitivity through the medial ankle. But that doesn't mean that that's pronation. That's dorsiflexion and pronation. Again, pronation does need the calcaneus to evert. It does need the talus, the midfoot, to do certain things. It does need the tibia to internally rotate. But again, this is the issue that emerges when we only think about coupling behaviors and not about how we can organize those interacting segments to ensure we're concentrating range of motion into a specific joint space or joint articulation between two interacting segments. So if you want to get ankle dorsiflexion, you of course want to try and reduce that tendency of the calcaneus to evert. Okay, so you're concentrating that range of motion. But what tends to emerge then is these kind of low load foot pronation coordination drills where people are trying to kind of gradually bring their tibia forward over the top of the foot and then gradually internally rotate the tibia to try and ensure that the calcaneus isn't dumping inward excessively. Okay, but the issue with that is just it's a very low load, low intensity drill, which can be helpful, but you need to get low into a tissue, into a structure of the body that is interacting with the ground. You need to get low into those tissues. And so if you're thinking about things from a kinematic standpoint too much, and again, we've spoken about this in some of the movement theory and rehab videos where we speak about how we should not confuse kinematics and kinetics. Kinematics represents how bones are moving relative to each other, but we also have to consider that there are muscular forces that also need to be experienced and managed and handled as we experience those segmental behaviors. And that's why we want to ensure that we're actually experiencing progressively higher loads through the plantar flexors, through the intrinsic muscles of the foot, the toe flexors, as we express these different foot and ankle behaviors. And when we're trying to work on coordinating segmental behaviors under low load, especially if that's all we're doing, and particularly in an area of the foot where there's multiple segments that can experience motion and make it challenging to concentrate motion at a specific joint, it becomes very messy. And I often see clients trying to do this and they just struggle to do that at home. There are easier ways as long as we have a clear intention set. Okay, so in that situation when you're trying to bring the tibia over top of the foot, you'll often see people doing this where they're bringing the tibia over the foot and gradually trying to internally rotate nice and slowly, getting the body over the foot. I would question, what is the intention of that? Is your intention to try to create pronation? Is your intention to try and create ankle dorsiflexion? Is your intention to try to slow down calcaneal eversion? For me, there's better ways, there's easier ways through which to do that, but that's not really a clear intention. You shouldn't really have an exercise where the intention is to slow down calcaneal eversion. The intention should be to, are you trying to create ankle dorsiflexion? Okay, in order to create ankle dorsiflexion, you need to try and reduce the tendency of the calcaneus to evert. And so how do we go about doing that? Also, how do we go about doing that as we get load into the muscular tissues? And so when you look back at some of the other foot and ankle videos that we've done, when we're working on foot pronation, when we're working on ankle dorsiflexion, we're ensuring that we are setting a position up that also makes it easy for us to experience load through the relevant tissues in a way that can be scalable, in a way that we can manipulate intensity, the frequency, the duration of the load, with a clear idea as to how we can actually progress and regress based on those foot and ankle behaviors. Okay, so a couple of things spoken about in this video. Hopefully it gives you a little bit more information as to the biomechanics of the rear foot, why that's important to consider when we look at ankle dorsiflexion, but it's also helpful to consider how the talus is moving relative to the tibia and the calcaneus as well. And of course, like always, if you have any questions, again, I'm hoping that people will have questions about this video because we did discuss a couple of different features. Like always, ask them below and we'll be happy to have further discussions. Okay, so thanks again for listening and we'll see you next time.